Okay, I hit the wrong button thanks to the baby being in here, so you're going to have 2 videos this week instead of 1. My apologies, but let's move on. Okay, so risk factors, infants and toddlers at risk for disability. So you have, you can serve them if they're at risk for a disability but don't necessarily have one diagnosed yet. They would be at risk if they are experiencing a substantial developmental delay if early intervention services were not provided to the individual. Risk factors include low birth weight, respiratory distress as a newborn, lack of oxygen, brain hemorrhage, infection, nutritional deprivation, a history of abuse or neglect, illegal substance abuse or withdrawal symptoms from prenatal drug exposure. And I've had several friends who've had premature babies, week 30, 32, and I know they've been closely followed by early intervening services after spending so many weeks in the NICU because of their low birth weight and their need for oxygen at birth. But most of them turned out to be fine. But I'm very thankful, I know they are too, for that service to be there in place to follow these toddlers and infants who are at risk before they actually show the developmental signs of delays, because the parents aren't going to know what signs are to look for. We as professionals do. So established risk, the 3 types of risk. Established risk is when an infant is born with an early identified condition, such as hearing impairment, Down syndrome. Then environmental risk would be when the infant, who might otherwise be biologically sound, encounters life experiences such as abuse or neglect that place them at risk. And a biological risk would be where my friend's children fall. They have low birth weight, prematurity, asphyxia, intracranial hemorrhage that suggest the possibility that early insult to the child's central nervous system may contribute to developmental delays. But again, nothing is established yet. And remember, again, as in Chapter 4, causes are layered, interactive, and multifactorial. So these children have a better prognosis for outcomes if they have parents who are attuned to their needs and doing good follow-up services. So predictions for later development risks based on formal tests administered during infancy should be regarded with caution. IQ tests in infancy and toddlers are notoriously unreliable. It's just too early to tell, and they have so many environmental factors that haven't taken place yet. So the assessment of cognition in infancy has only limited ability to predict later developmental outcomes. So we must use caution if we're using an assessment to determine the toddler's or infant's degree of risk. But we have to remember that certain familial factors will have a better prognosis and influence on those children's developments. So the Individualized Family Service Plans, or IFSPs, must have 8 components, just like the IEPs that we discussed earlier in Chapter 4, I believe. All of the required components of an IEP, these are the required components of an IFSP, and I think we'll get back to an IEP in the next chapters too. So you have to have the child's status, including the present levels of physical development, cognitive development, communication development, social emotional development, and adaptive development. This matches the present levels of performance on the IEP when they reach age 3. You have to have family information, including with concurrence of the family's resources, priorities, and concerns. The family's giving input and must be included on the IFSP. Again, the family component of IFSP is critical and essential to the planning and implementation of early intervening services. And that's a component that you don't see as much once they turn 3. And that's the discussion question this week. What are the advantages and disadvantages? But the family has a lot of input. They're giving you the priorities. What's their number 1 priority for their communication needs or for their physical development and their concerns? Number 3, measurable results or outcomes expected for the child, including pre-literacy and language skills as developmentally appropriate, and the family, criteria, procedures, and timelines used to determine progress and whether modifications are necessary. These timelines are a little bit shorter than school timelines for IEPs, and the family needs to help set those goals, results, or outcomes. Early intervention services, which are based on peer-reviewed research, to the extent that's practical, to meet the unique needs of the child and the family and to achieve the results or outcomes identified, including length, duration, frequency, intensity, and method of delivering the service, such as at home or in a child care environment, natural environment setting, and then justification for any service not to be provided in a natural environment. So if you're only going to provide it in Head Start rather than in the home, or if they're in the NICU and they're receiving the services in the hospital-based services. This is all on page 219. The PowerPoint's just the highlights, but 219 has the detailed explanations of all of these 8 components. 5 would be other services, including medical and other services child or family needs and receiving through other sources, but aren't required or funded for this part. So this might be the description of the service coordinator might need to assist the family and child in securing those other services. 6, dates and duration, including the projected date for the initiation of each service and anticipated duration of each service. So if they start immediately when they're discharged from the hospital because they're hearing impairment, then they might not have a discharge date, or their duration might be up until they turn age 3, because we know those services will be needed throughout their early childhood experience. A service coordinator is the person representing the profession most immediately relevant to the child or family's needs, who is qualified to be responsible for the implementation of the early intervention services, including transition and coordination to schools if necessary. And then transition from Part C services, including steps to support the transition of the child to preschool, early education, Head Start, or early Head Start, or child care programs. From Part C to Part B services, but it has to be in the IFSP from the beginning. These types of services provided to families and children must be individualized in the needs of each child or family. So again, everything is individualized. You might have a variety of services listed for potential coverage under IFSPs. Page 220 lists all of these services, including family training, counseling, home visits, special instruction, speech-language pathology, audiology, sign language, cued language, occupational therapy, physical therapy, psychological services, service coordination, medical services. The list goes on and on. And so the variety of services must be provided by qualified professionals, including speech-language pathologists, special educators, audiologists, occupational therapists, physical therapists, psychologists, social workers, family therapists, family counselors. There's a lot of family mediation and counseling involved in early intervening services. And then in the transition from IFSP to IEP at the child's 3rd birthday, so before they turn age 3, is the responsibility of the school to identify the children and if appropriately rule them eligible for services and have an IEP in place by the time that they turn 3, the date of their 3rd birthday. However, the family can elect to not do an IEP, not transition to Part B and continue with Part C services, but I've never worked in early intervening services, so I'm not very familiar with whether that option's ever exercised very much. All right, so again, services are individualized to child and family. You have a variety of services provided by qualified professionals, and the transition from IFSP to IEP at the 3rd birthday. Again, IFSP is family, IEP is child. The IFSP must be revisited every 6 months. And then services must be provided in the natural environment. Okay, so IFSP services every 6 months, but a actual revision of the IFSP is now required only once per year, as is with the IEP. But they would like to see an every 6-month revisitation to the IFSP to see how they're making progress, because again, the developmental milestones are so close together, and there's such a difference between a 6-month-old child and a 12-month-old child that we need to be closely monitoring their progress and providing natural environments. So family-centered services, again, everything's based around the family, so that means it's delivered in the natural environment. And then we need to be including sensitivity to cultural linguistic diversity, just as we do for every assessment. But really, we need to know what the expectations of the family are, and regarding their child's language, communication, and hearing needs. So as clinicians, when we're providing culturally, linguistically sensitive or culturally competent services, as clinicians, these are some of the things we need to do. We employ fewer questions and more active listening. We have we can do techniques such as direct interactions with the child and the family. We need to be observing them and how they're interacting with each other. We can do the ethnographic interviewing. We can do joint observations, whereas the parents and the clinician observe the child together and see what the child is doing, and then base the goals and objectives on what they're observing in the child. And then we have discussions with parents about factors that facilitate or inhibit child participation. So this is how we get the child to communicate more. This type of behavior might inhibit or prohibit the child from growing language and communication. So we need to use a language that the parents can understand. We don't need to talk in technical jargon. It needs to be on their level, and so we need to be considerate of their cultural background, of their educational background, and what it is that their knowledge base is. You can talk to parents in different ways, and even parents who are from educated backgrounds aren't necessarily going to understand our speech terms. I was having the conversation with my friend who has her child in early intervening services, and even this is an educated parent, upper middle class person, but I was trying to articulate certain aspects of the services that she's getting, and I had to rephrase it and make it on her communication level as far as what she's understanding as a lay person, because lay people don't necessarily understand all of our technical jargon. So we need to be considerate too that parents often are coping with these newly established and newly diagnosed disabilities. You may not know you have a hearing impaired child until that child's born. So you have this child that comes out all 10 fingers and 10 toes and looks perfect, and then they have that hearing test in the hospital. Well, we have a profound hearing loss and we're never going to be able to hear. That's shocking to parents. And so they're going to go through stages of grief, and just like someone who's experienced a more catastrophic event with a child, because you have these expectations that now you're not sure if that child's going to be able to meet that. Now, of course, as clinicians, we know that we can do a lot to make these children successful, particularly when it comes to hearing impairment. But it's very shocking for parents initially, so you need to be very sensitive to that as you're approaching this in the hospital. So there are factors that influence families' better ability to deal with these, including the characteristics of the child's diagnostic condition, family size, family form, cultural and religious factors, socioeconomic elements, and the geographic region. So the parents approach these in different ways. Some families face multiple risks, including caregiver risk because of where they're coming from, such as low socioeconomic status, absence of one or both parents, emotional or financial challenges, substance abuse issues, and other barriers to caregivers' ability to cope. So those barriers would make that child be higher risk for less success than the families who are coming from the higher SES status, and they're more educated and they have more cultural and religious influences. So we need to be, as teams, we need to be patient, persistent, respectful, and sensitive about the services we're providing. And I've even experienced this in schools, and that the parents can be very defensive and very angry about what's going on with their child, and you are the reciprocant of that anger. And so you just practice patience and remind yourself that this is not directly against you. It's with them dealing with the condition and the problems that their child is having in schools. So providing culturally and linguistically appropriate services. We need to evaluate our evaluation development must be considered in a culturally fair manner. Our views and attitudes about disability vary across cultures and across families within culture. So we need to be considerate of what they're coming from, what their culture perceives about disabilities. Remembering, of course, discourse expectations vary. Some children are seen and not heard. That is very much a part of certain cultures even today, versus our culture as an SLP, for instance. You're not going to probably have that culture with your child about if you're talking to adult or adults are around, then the child's not expected to have any conversation whatsoever. Additionally, adults change the way they talk to children, and they use lower vocabulary and smaller sentences with children, thinking that they can't understand it, they can't learn it. And of course, as SLPs, we know it doesn't matter what we're saying, they're constantly acquiring and applying this vocabulary that they're learning. So I don't change my vocabulary for my children, whereas another parent might. So parents are not expected to assume roles that conflict with their cultural values. If the child is seen and not heard, if that's their cultural value, then you must be considerate of that, but also educate those parents to bring them around to the ways to enhance language development and grow language in those children. Maybe not necessarily in the social context where the children are seen and not heard, but in that home context when they're with that child every day. Also, cultures differ in views of disability and developmental differences. It uses the example of Native American languages where they don't have words for retardation or disability because those individuals with differences are just seamlessly integrated into the community and not perceived as having any difference. So if they view them as we don't treat them any differently, that's going to change the way we're treating them in our services that we're providing. So we need to be aware of that. So appropriate cultural linguistic practices are required when assessing English language learners, including assessing them in their native language. This is a very controversial topic because we are definitely having larger and larger populations of English language learners in Mississippi and throughout the United States. We don't necessarily have bilingual speech-language pathologists or assessors, so the best way to assess them is with the use of an interpreter. But as the book points out, you can't just interpret the assessment as it is because you're going to lose certain syntactic and semantic and pragmatic features of what the test is trying to assess. Just like in Spanish, you put the verb before the noun, and in English you put the noun before the verb. So if you're trying to assess an English language learner who speaks Spanish using a self, you're not going to necessarily be able to score that the same way on the standardized measure because it's not designed for Spanish speakers. It's designed for English speakers. So usually multiple assessment methods that aren't necessarily standardized, but assessing their overall conversational communication ability with the use of an interpreter that you've trained is the best method for this. And they do have Spanish assessments out there, but you don't necessarily have a Vietnamese assessment out there or Chinese or the different dialectical variations within Chinese speakers because there's just not one Chinese language, just like there's not one English language. We have all these dialectical variations. So it's a very complex issue, but so we use interpreters to the best of our ability to assess them, and parent input a lot too about what the expectation is and what the child's doing, and is this appropriate or inappropriate. So again, we don't always have to have formal testing or labeling. We can just do an informal assessment, and we don't necessarily have to give a label because the great thing about early intervention is that, again, if they're at risk for the problem, we can provide services without having an established diagnosis. And then I like this point on the bottom of page 224. It takes time to earn trust and become familiar with the cultural expectations of families that differ from one's own. So it may be tempting for clinicians to avoid cross-cultural and different language situations because we have a lack of confidence about reaching a valid decision, but you don't need that to stop you from providing appropriate services to children. And it can be enriching to make the effort to gain deeper understanding into a particular family's worldview and expectations and dreams for their child. So don't let that lack of confidence keep you from having that new experience of culturally linguistic diverse services to a child. All right, now we're moving into natural environments for services. Again, these are family-centered services, and the natural environment are settings that are typical for infants and toddlers without disabilities or delay. So this can be in the family's home. Most often it's perceived as the natural environment, but as they get a little bit older, they may be moving into a preschool environment, so that might be more appropriate. You have hospital-based services. These are for high-risk neonates that receive hospital-based care. SLPs in the hospital, they're part of the team. They can provide evaluation and intervention for swallowing, communication, and feeding needs. They can conduct parent, caregiver education and counseling, and then engage in team education and collaboration. Because if a child is receiving services in the hospital, this is obviously a very complex, medically needy child. And so there needs to be a lot of parent education there. But the research shows that parents are more engaged earlier when they are supported and taking a role in their child's care. So again, that hearing impaired child has a better prognosis for growth, because initially that parent knows right off the bat, okay, if they're hearing impaired, so I need to change my communication method to meet their needs. I need to be more visual. I need to be looking at them and make sure they're looking at me, and use lots of gestures so that we can use a multiple sensory approach to communication, versus the child who's hearing impaired, but the parents don't get that diagnosis until they're age 3. And here they've been communicating them primarily orally, and the child's not receiving that input. So the earlier, the better. Okay. Home-based services, these are accessible and reasonably economical settings. So that's for services that are often provided in rural settings and for families with limited transportation. We have lots of families in my area that don't have transportation to get to a clinic or even get them to school. So the bus services are the only way the children get to school. And of course, prior to that, when they received early intervention services, they received those home-based services. The clinician came to their home because they were so rural and had such economic needs. Home-based services might serve as transition services from hospital to home. So again, if a child has some complex medical conditions or swallowing or feeding care, you might need to transition them and train the families to meet the feeding challenges of a child with oral motor needs. And then you have a focus on early communication and development in the home-based services. So we're going to talk a little bit later about how to train parents in these procedures. Center-based services, this is where the families bring children to a center or clinic, not necessarily a speech-language clinic, but any type of place where it's family-centered and there are multiple parents or caregivers coming to participate in circle time. So those children have the peer interaction and the parents have the family interaction as well, because we know children learn best from others in their environment, so we can get a lot of benefits from peer exposure and peer provided services, or peer enriched services. Not provided. Peers aren't going to provide the service. They provide the model, and we grow that model for them, for the children we're serving. And then daycare and clinic room services, services in daycare and early childhood settings, such as Head Start or Early Head Start or any early childhood provider. Okay. So now the primary treatment method for this is scaffolding. And the next chapter really discusses a good bit more about how to implement more services at the preschool level, but I'm sorry. The next chapter, infant and toddler services intervention. The next chapter is going to discuss the intervention. This is just kind of leading into intervention and our primary means of growing children. So scaffolding language. Scaffolding is key in family-centered services, and you all got the question right about what scaffolding was, about bringing the child up a level. So we invite parents' active participation and empower them to serve as partners in assessment and intervention process. So we're teaching parents how to scaffold learning. In infancy, parents play the primary role of communication development because they're with them every day. And of course, the infants aren't communicators yet, so there's not very much scaffolding with a clinician and an infant, but there's very much happening with the parent and the infant. And then with toddlers, clinicians provide more direct services. Now, the roots of scaffolding, talking about those theoretical roots, it's a combination of cognitive constructivism and social interactionism theories. In addition, we have that zone of proximal development that Vygotsky talked about, that children have ZPDs that are more constricted and have lower thresholds. So we work within their zone of proximal development, within their zone of learning, taking what their knowledge is and bringing them to the top level of their knowledge. Okay. So with scaffolding, most parents intuitively scaffold infant early communication interactions. So they slow down, they simplify, they exaggerate. It's funny because I'll listen to my husband, who's not an SLP and not trained in this, but I'll hear him scaffolding and changing his tone and changing his interaction for Cecile. And of course, we know this as Mother Ease. We change our tone and change the way we're talking to bring those to bring the infant's attention to what we're saying, and they start listening and paying attention to that. So the research also shows us that infant brains are predisposed to mirror their parents' input And then engage in the human empathy, affective resonance, understanding, attention and intentions, observational learning, and language acquisition. And of course, this would be a big red flag for autism spectrum disorders if children aren't engaging in these mirroring of their parents. But we can see Cecile all the time. You smile, she smiles. You say, hey, and she says, hey, and she imitates you, and she even inflects. So you can see that mirroring very early on. So intervention strategies that we can use to bring this up. Let me back up a minute. Scaffolding for children with disabilities or risk for disabilities. Even if a child has a disability, we don't need to change how we're scaffolding or how we're talking to them, because they still have the potential for learning. It might be a slower rate of learning, but they still can learn. I like this personal reflection 8.2 on page 228 from Rhea Paul. Instead of asking parents intimidating assessment of their own communication skills, we better off ask them what makes communicating with their child hard for them. And that's very much that ethnographic interviewing type of strategy. What's difficult when you try to communicate with your child, so we know how to help them communicate more easily and effectively. So early intervention strategies. We have responsive interaction strategies. This is recasting. Kennedy, for instance, is saying fixing to. And that's one of my little, oh no, we're not going to say that. We're getting ready to, or we're about to, because that's very much a Southern dialect grammatical characteristic. So she'll say, I'm fixing to go do that. I say, oh yeah, you're about to go do that. I'm about to go to the store. So you recast it. You say it again, but with the correct structure and grammar. Directed interaction strategies. These are based on behaviorist principles such as prompting, shaping, reinforcing, and fading. So it's a little bit more direct, directly targeting things. And then blended strategies are direct behavioral strategies in natural environments for generalization. Some direct types of strategies would be targeting pronouns. I see the boy. Let's make an I see sentence. You have a picture, I am, and it's a boy running, or you can have a picture of the child doing an action, running, eating, sleeping. What are you doing? I am running. I am sleeping. And having it in a group interaction too. So the person holds the picture of what they're doing. I am running. Pass it to the next person. And child, the one that has the target behavior. I am running. So very much structured, repetitive types of instruction. Okay, so intervention scaffolding. These are the ways we can target scaffolding through intervention because learners play an active role in acquiring new skills. That's cognitive constructivism, and others can mediate learning, social interactionism. Again, learning from those peers, or in this case, learning from the families and adults in the environment. So we have social mediation. The mediators frame cues and focus a less skilled learner's attention on contextualized cues to enable him to construct a more mature cognitive linguistic schema. This is goal-directed and deliberate. You're targeting a certain skill, such as vocabulary development, naming pictures, doing the actions with the pictures. They're framing, selecting, focusing, and feeding back environmental experiences to produce in the child appropriate learning sets and habits. I'm thinking about this even at the infant level. Cecile pointing and indicating something that says da, da, da for a drink. So I'm interpreting it as that. Others can be interpreting it as drink. But she says da, da, and I'll say yes, drink, drink, and I'll incorporate the sign for drink as well as the oral output for drink. And then as I'm doing this, I'm seeing more and more of her incorporate not necessarily all the phonemes, but she'll say da, and she'll indicate the sign for drink or for milk, oftentimes because she might have a bottle or milk that she's pointing to. So, building them on what they have. She has da. So how can I take da and move it into that or drink and more phonemes? And that's incorporating the sign plus the oral input. Okay. Conversational recast. This combines modeling and feedback. You have expansion of what they're saying, extending it. So they say, They say drink. She gets to drink, because she's saying drink, or she's signing drink. And then you incorporate more. Want drink. Want drink. I want drink. Still a very simple sentence, but those two word combinations. So the clinician responds to child by producing slightly more mature model, but not very much. I like this figure 8.2, tips for scaffolding, the acronym for scaffold. Start with something the learner knows. This is page 229. Comment on cues in the context that can help the learner form new connections. Ask questions that serve as guides, not tests, and allow wait time for processing. Frame cues the learner may be missing and focus attention on key features of the event. Feed back information to help the learner identify mismatches and fix inconsistencies. Ownership means encouraging the learner to set goals, take the lead, and explore original ideas. Listen to the learner's message and respond contingently to the meaning, and don't forget to take the scaffold down. Learning is not complete until it can stand on its own, so don't be afraid to take it down a level if it's too far above what they're doing. Okay. And then finally, conversational recast. I just did that. Then focus stimulation. Adults expose children to multiple examples of a specific linguistic target within meaningful linguistic context. So the storybook targeting the actions, or the pictures targeting the actions, and maybe the pronoun I see or I am. So anything we can do to expand their model, but we're focusing a specific target, maybe action words. It might be naming objects or naming pictures, whatever it is that we're targeting. I'm thinking pronouns because I'm thinking of the higher level 3 and 4-year-old that I work with. But at the infant level, it's very much that initial vocabulary building and stimulation. Okay, so how do we teach parents how to scaffold? These are 3 approaches the book highlights. The ecological approach, or ECO, as developed by James McDonald in 1989. It has these 5 principles. Partnership principle involves teaching parents to engage in balanced turn-taking. Matching principle involves teaching parents to interact and communicate at a level the child can match. Sensitive responsiveness principle, which is teaching parents to scaffold the child to teaching parents to notice and respond to subtle advances in child's ability. Child-based non-directiveness principle, which is teaching parents to scaffold the child to construct new concepts using child-centered rather than adult-directed procedures. And then emotional attachment principle helps parents appreciate the importance of the stable base of emotional attachment for preparing the child to form relationships with others. So this is a very structured approach of how to work with parents in those early intervening services and teach them how to scaffold. The next model the book lists is development, individualization, and responsiveness, or the floor time model. I know you've probably heard the floor time model, particularly if you've been working with students with ASD, because that's really what their target was initially. And they have the DVD training series. So the developmental is understanding the child's emotional development relative to 6 milestones: shared attention and regulation, engagement and relating, purposeful emotional interaction, social problem solving, creating ideas, and connecting ideas together, and thinking logically. Individual differences, which is the child's unique way of taking in the world and responding to it. And then relationship-based parent interactions that fit the child's state of development, and individual differences. So a lot of this we understand and we're familiar with, and it's teaching parents how to read what the child is doing and interact with them and bring it down to the child's level, because this is what we spent all of our years at undergrad and graduate school and clinical supervised practicum service and in our CFY learning how to do, is interact with the children on their level. But it is more effective if we can train the parents and the caregivers to also have these skills. And again, we're naturally scaffolding. It's just teaching them how to target it based on what the child is showing in their communication skills. Then the Heynen, It Takes Two to Talk series. It's been subject to a lot of scientific investigation, and you receive specialized training to go through this. I'm familiar with it. I've never been able to participate in the training, but it's very popular when it comes to family-centered services. So these are the principles. You have child-centered strategies involving getting face-to-face with the child and following his or her lead, with the acronym OWL: Observe, Wait, Listen. You have interaction promoting strategies, which involve balanced turn taking, parents matching their turns to the child's, asking questions to keep conversation going, and waiting for the children's turn, using cues only when needed. And then language modeling strategies, which involve using contingency techniques to interpret experience, expand on what the child says, and extend the topic. So, this has been extensively researched, and some of the research is indicating that there's an advantage when parents extend children's contact and meaning over when they expand grammatical language structures. So putting it into a longer sentence is good, but extending the conversation and keeping the conversation going is better, keeping the child talking and interacting. And a lot of this research has shown that the Hanen program, I know they've done a lot of research with how it can be put in place for families of Head Start or early Head Start programs, but it seems to be very beneficial for the middle class families, more so than those with lower socioeconomic status, probably due to the educational background of the families and what they are coming to the table with as far as their knowledge. But it did show, the research has shown parents were taught to think about how they might target each language objective using the particular routines and interests of their child, following the child's lead in naturally occurring situations. So again, everything very child-centered, following the child's lead, that seems to be very effective. And then more research, this is on page 233 at the bottom of the first paragraph. The toddlers with expressive language delay, focusing stimulation on particular linguistic targets rather than more general language or learning stimulation is more effective. So they have expressive language delay, it's more effective to select a linguistic target and implement that rather than just giving them a general language stimulation, language enriched environments. So we need to be considerate of what the child's problems are. Is it a receptive delay versus an expressive delay? But the scaffolding approaches outlined here, they're consistent with the context-based assessment and intervention philosophy of the book. That's why particular attention is given to this methodology. So let's move into assessment of infants and toddlers. There are some formal assessment tools out there. Table C in Part 3 appendix, that is page 512, lists particular assessments for this population. You have various vocabulary and communication checklists. You have standardizing criterion reference tools using direct observation and parent report. And then you have other measures of cognitive development. But again, the cognitive development measures that give an IQ score need to be exercised with caution. And they must be administered by a credentialed psychologist. But some of the ones the book lists for the vocabulary and communication checklist, it's MacArthur Bates Communicative Developmental Inventories. Some formal tools are the Rossetti Infant Toddler Language Scale and the Communication and Symbolic Behavior Scales are two examples they list for formal tools. I've used the Rossetti Infant Toddler Language Scale before in assessment. Then informal assessment probes, these are considered more authentic and ecologically valid because they're fully individualized and situated in naturalistic context. So, along the lines of our grammatical analysis that we might do with an older child or conversational speech analysis, informal assessment, looking at the child, observing them, and seeing what they do. So you can use the 4 questions of context-based assessment in Chapter 1. What does the context require? What does the child do? What can the child do differently? How can the context be changed? Those can easily guide your informal assessment probes. You can use this to get baseline data, and then observations later will be able to document change in the child's behavior. This says video recording. Digitally record probably is the better word, but I guess it's a digital video because no one actually has camcorders anymore. But video recording the natural samples is the best method for informal assessment because you can go back and evaluate the eye contact and joint attention types of skills that you're monitoring. And then you can also do this with the parents. So you want to watch the video together to see what you're observing and what the parents are observing and what things you can change and do differently to maximize that child's language potential. So short samples of parent-child interactions can be videotaped in multiple contexts. You want not just you, the clinician, and the child interacting, but the parent and the child. So what can we do to bring the parent up in their scaffolding skills and their teaching strategies to enhance that communication environment? And then informal developmental checklists and observational charts completed by clinicians and parents are helpful for structuring collaborative discussions by interdisciplinary teams of professionals and parents about a particular child's needs. These are very helpful in guiding your intervention process. So that is it this week for IFSPs and infant toddler assessment practices.